Assalamu alaikum.
Assalamualaikum everyone. My name is Dr. Zarek Sarkun. I'll be presenting today on a topic on adrenal tumors, its evaluation and management. The anatomy and endocrine function of adrenal gland. It is a paired endocrine gland situated over the medial aspect of the upper pole of each kidney. Each weighs approximately 4 to 5 grams. There are three functional zones: zona glomerulosa, which secretes aldosterone; zona fasciculata, which secretes cortisol; and zona reticularis, which secretes androgens. The inner layer, which is called adrenal medulla, it is medullary region secretes catecholamines, epinephrine and norepinephrine directly into the bloodstream, responding to the sympathetic nervous system stimulation. This is a transverse section and microscopic section of adrenal gland showing cortical zone and medulla.
There are three zones like in a kidney. To remember the three zones, there's a mnemonic GFR MGC for cortex, glomerulosa, fasciculata, and reticulata. And the hormonal major component they secrete is MGC. The glomerulosa secretes the mineralocorticoids, fasciculata secretes the glucocorticoids, and the reticulosa secretes the catecholamines, androgen, sorry. And the medulla, it secretes the catecholamines, epinephrine or epinephrine. And in androgens, the mostly the first procedure in the residency we all do is a VSO, just to suppress the testosterone production. 90% of testosterone is secreted from the testes, other 10% secreted from the adrenals. So it is the reticulosa which secretes the testosterone. So these small glands, they are vital and they are compulsory for the daily life, daily routines to maintain the blood pressure, to maintain body posture, skin turgidity, heart rate, your bowel symptoms. So, so if a patient is having bilateral adrenal gland removed, the mortality is very high. It is written in the our textbook that bilateral adrenalectomy is the most mortal procedure, not the mortality. It, like if you do not support the patient's body with all three components of the hormone via enteral or parental route, the patient may lose his life in a 48 hours or in 72 hours. And we have seen the patients who have undergone bilateral adrenalectomy, and we have seen them going away from this world in a 7 days, going away in the cardiac failure, lung failure, and kidney failure. So the evaluation and the understanding of pathophysiology and normal physiology of adrenal is very important. This so that's why most of the time when we deal with the kidney, non-functioning kidney, we preserve the adrenal gland. And in the tumor of kidney, which is abutting the adrenal gland in the upper pole, it is said that when you see the kidney and adrenal gland peroperatively, if it is spared, you should spare the adrenal. If it is involved, then you have to remove it.
Adrenal tumors are divided into functional and non-functional tumors. These include Cushing syndrome, hyperaldosteronism, and pheochromocytoma. Cushing syndrome presents with central obesity, moon facies, buffalo hump, purple striae, hypertension, diabetes mellitus, osteoporosis, and depression. Hyperaldosteronism presents with resistant hypertension, hypokalemia, muscle weakness, muscle cramps, polyuria, nocturia, polydipsia, and headache. While pheochromocytoma presents with hypertension, paroxysmal septal palpitation, profuse sweating, severe headache, anxiety, panic attacks, tremor, chest abdominal pain, pallor, or flushing. It is also non-functional tumors, often asymptomatic until large enough to cause mass effect, abdominal or flank pain, alisticity, or discovered incidentally on imaging performed for other reasons.
These all symptoms have a basic concept behind why in Cushing syndrome and the cortisol is secreted in excess, why there is central obesity. Zaka, why buffalo hum? Cortisol is a glucocorticoid, so it increases the circulating sugar. So when the sugar is high, it will convert into the glycogen or fat and it deposits in the body where it can easily deposit it, like in the abdomen and all those parts which are not routinely moved by body. For example, you use your legs and arms daily, So these parts they use the fat and glucose for their energy. But to use the abdomen, we have to do some extra exercises so that these muscles can be utilized. Back of the shoulder, back of the neck, we don't use it regularly. So these areas where the use is minimal, the fat deposition will be the maximum in the hypercortisolism. And the patient will be having the increased RBS, he will be diabetic. The purple stria, why there are purple stria, why there is hypertension, osteoporosis. These all are linked with the cortisol normal functioning mechanism. And same aldosterone. What is the basic function of aldosterone? Then how? It will increase the intravascular absorption of sodium. तो क्या होगा भाई? जहन तो इससे क्या होगा? और मसल फटीग होगी, कम होगा, पोटेशियम तो बाहर जा रहा है। हेडेक तो समझ आ गया, पॉलीडिप्सिया समझ आ गया कि सोडियम ज्यादा बॉडी के अंदर है तो उसे ज्यादा पानी पीना पड़ेगा ताकि प्यास लगेगी, सारे सेंट्रल सिस्टम एक्टिव हो जाएंगे। So like this, these are the functional adenomas. Pheochromocytoma is functional, not functional. It is functional always if it is a pheochromocytoma. The symptoms will be hypertension. Why there is a hypertension if pheochromocytoma and palpitations are there? Due to the secretion of catecholamines. Profuse sweating, headache, anxiety, panic attacks, tremors, chest pain, pallor, flushing. These all deals with the products they are secreting. So these are functional. Otherwise, you can also classify the adrenal gland, any type of mass according to its zone. Like in glomerulosa, there can be adenoma. There can be any secreting tumor. In medulla, there can be adenoma. There can be myelopoma. There can be pheochromocytoma. There are two, three things you have to understand. The classification is based on local relations, the secreting products of that mass or the local mass effect. So if you are going to evaluate, you have to have the knowledge of basic physiology of these type of products they are secreting. And you have to also identify the mass effect of these adrenal gland. The adrenal is situated on the top of a kidney. If it is a too huge, it can page the kidney. If it is too huge, patient can have lump or abdominal swelling. It can also compress the IVC, aorta. It can push the diaphragm upside. Patient might present to you with hiccups which are uncontrollable. Patient might present to you with all of the symptom of Cushing disease or syndrome, buffalo hump, central obesity, an awkward posture, hypertension, postural hypertension. He might say that whenever I stand, I fall back, or I have a blackout. Whenever I sit, I have a blackout. So you have to evaluate. And there's another concept that there are two adrenal in the body. If one is functioning or one is overcompensated, the other might be depressed. So the patient, the adrenal which is involved by the mass, it is secreting something, but the other adrenal might be suppressed. So whenever you do the surgery of one adrenal gland, you have to support the other also, because it takes up to 12 months to other adrenal gland to keep the pace up for the normal daily routine. आगे चल।
The biochemical evaluation, which is diagnostic screening panel. Cortisol excess, clinical syndrome like Cushing syndrome, or mild autonomous cortisol secretion. The primary test is 1 milligram overnight dexamethasone suppression test. Cutoff value morning serum cortisol more than 1.8 microgram per deciliter suggests autonomous secretion. Confirmatory test 24-hour urine cortisol or late night salivary cortisol. Indication all adrenal mass, especially with clinical features.
How this 1 milligram overnight dexamethasone suppression test work? How you can evaluate? If a patient is secreting glucocorticoids and you want to test it is cortisol excess or not, you give extra matlab, extra glucocorticoid functional hormone or product like dexamethasone to the body. Low dose means you have given 1 milligram overnight, but you will then check the early morning cortisol level. If these are high, this means that it is autonomous secretion. This adrenal gland is not under control. It is not under control of your dexamethasone in the serum. It is acting on its own. So it is neoplastic phenomena that the body is not having the control of the particular part of mass which is secreting that product. So in normal body, for example, in us, in a normal person who is not having any adrenal pathology, if you give a parenteral dexamethasone, your cortisol level is decreased according to the renal our normal neuropsychiatric pathway, it will be suppressed. But in their tumor, it will not be suppressed because it is secreting on its own. And once you have confirmed that the patient is having hypercortisolism due to because overnight dexamethasone suppression test is positive, negative patient is not behaving accordingly. So you will confirm it by high dose dexamethasone suppression test. तो ये माइंड में होना चाहिए कि अगर जिस तरह हमारे कुछ बॉडी बिल्डर्स इंजेक्शन लगाते हैं टेस्टोस्टेरोन के या स्टीरॉइड्स के, तो उनकी टेस्टिकुलर एट्रोफी हो जाती है, उनके एड्रिनल सुप्रेस हो जाते हैं. जब वो उसको छोड़ते हैं टेम्पररी तौर पर तो बॉडी मास मसल बल्क सब चीज़ें बन जाती हैं, लेकिन जब उसको छोड़ते हैं तो क्या होता है? देयर आर लॉट ऑफ न्यूज़ इज दैट द बॉडी बिल्डर ही डाइड सडनली इन यंग एज because they have suppressed their both of the potential life-saving hormone products with extra parenteral hormone steroids. Initially, this is normal, but later they will suppress permanently. And to awake those adrenals and those testes, it is very difficult.
Catecholamine excess clinically presents with phlebotomocytoma. Primary test is plasma-free metanephrines or 24-hour fractionated metanephrines. Sensitivity is 96 to 99% for detecting pheochromocytoma. Clinical pathology must be ruled out in all cases before any invasive procedure because it's a risk of life-threatening hypertensive crisis during biopsy or surgery. Aldosterone excess. Clinical syndrome presents with primary aldosteronism like Cone syndrome. Primary test is plasma aldosterone to renin ratio AR. Interpretation is ARR more than 20 to 30 suggests primary aldosteronism. Clinical indication is hypertension or unexplained hypokalemia associated with hypokalemia, metabolic alkalosis, low plasma renin activity. Critical safety principle. All patients with an adrenal tumor require biochemical evaluation for hormone overproduction, even in the absence of obvious clinical symptoms. Pheochromocytoma scanning must be completed before any invasive diagnostic procedure, biopsy, or surgery to prevent potentially fatal complications.
How to evaluate that which type of adrenal gland is secreting more cortisol or aldosterone? Hamza? How to evaluate the which right or left, which gland is excreting more cortisol, either it is left or right? Because when you take the sample from peripheral vein, it have the blood or venous supply from both of the adrenals. How you can differentiate that the right side of adrenal is hypertrophied or it is hypertrophied, but it is excreting more of the cortisol which is contributing in the body?
Adrenal waste sampling. Adrenal waste sampling.
How to do adrenal vein sampling? थोड़ा सा enlighten करते हैं. It is an invasive procedure. How to do it? You can do it laparoscopically, you can do it robotically, you can do it with the help of intervention radiologist. How to do it?
By the intervention radiologist.
The expertise you have in your institute, you will use that thing first. But there's a famous question: whenever you remove any organ of a body, like you have to do the nephrectomy, or you have to do the lumpectomy, you have to do the retroperitoneal lymph node dissection, tumor of any part of the body. First, you will ligate the artery. You want to decrease the blood supply which is coming toward that part of the body.
The crisis.
But if in the adrenal no matter which type of mass it is, if it is proven or it is not proven, first you have to take control the vein. How? Why?
To save the crisis, adrenal crisis.
Because the products of adrenal gland, this is a mixed type of gland, exo and endo both. So they secrete their products via adrenal vein, then it comes inside the systemic circulation, then they act on the whole of the in every part, every system of the body. So you have to clamp or you have to take control of the adrenal vein first. How many adrenal veins are there? Shumaila,
3.
adrenal has 3 veins.
Or adrenal tract.
Adrenal gland has 3 arteries, major and single vein. Otherwise, it has minor, small arteries separately. So one artery is from the inferior phrenic artery.
Phrenic
Second one is from aorta.
and renal.
Third one is from renal artery. And both 3 arteries, they supply the single adrenal, and all the products of adrenal, they are excreted in the vein. The right side of adrenal vein emptied into
IVC.
and left side
Renal vein.
renal vein. So whenever you deal with the donor nephrectomy, you have to on the left side, you have to take control the gonadal vein, and another one is adrenal vein. You have to clip and cut. So on the right side, you have to take control on the adrenal vein, it entering into the eye, which is very small. Very cautiously, you have to take it on the sling, or you have to apply the clip over it. That's why whenever in a non-functioning kidney or in a huge pyelonephrotic kidney, you have seen the adrenal, it is disrupted. The bleed, it is difficult to control the bleeding. Which artery you will ligate? It will be very difficult to identify. So there is a plane of about 1 centimeter in the kidney and adrenal gland, which is of fat. So you have to do the dissection of upper pole between those kidneys, so that you cannot disrupt the adrenal gland. If it is disrupted, you have to fracture the adrenal. This is a term, fracture of adrenal. Like you have to take the 3 or 4 stitches of vicryl around the adrenal and just tight it. If you tight it too hard, this gland doesn't have any, no, not any. It is have very minimum content of the fibrous or component or fat. So whenever you take the stitch and tie it over the adrenal, it will cut through. You have to take some fat and control it. The mean same like this, when you deal with the adrenal mass or tumor, if you dissect the adrenal gland more, or if you move it away, so it will stimulate the adrenal gland to excrete its secretion. If it is a functional, non-functional, it will excrete its products of all 3 zones and medulla in the adrenal vein. The patient will be having the symptom of hypertension peroperatively. So if patient is not having the proper volume inside his body, or patient is not having the previous history of alpha and beta blockade, and you are dealing with pheochromocytoma, there's high chances the patient might have the systolic BP of more than 300 during peroperatively. And if 300 BP means that after recovery, your surgery went well, but when the patient will get awaken from the anesthesia, he will be having some of the part of his brain function diminished. To maintain the blood pressure according to the normal homeostatic algorithm of body, you have to control the adrenal vein in all adrenal gland surgery first. Like this catechola means they have epinephrine, norepinephrine. What is the basis function of epinephrine and non-epinephrine? Aliha, Nida, what is epinephrine? एक पेशेंट आईसीयू में, उसकी हार्ट, उसका क्या कहते हैं, पल्स रेट कम हो रहा है, बीपी कम हो रहा है, तो आप क्या स्टार्ट करते हैं?
नॉरेड स्टार्ट करते हैं फर्स्ट.
Norepinephrine start. These are vasopressors. What they do? They dilate the vessels or they shrink them.
Construct करते हैं vessels.
If normally in the patient who doesn't need any of these vasopression, but you are dealing with adrenal, they have secreted the huge amount of epinephrine and non-epinephrine in the body. What will happen?
I don't know.
Hypertensive crisis होगी ना. सारी बॉडी की वेसल जो हैं वो कॉन्स्ट्रिक्ट कर जाएंगी, तो उससे क्या होगा? परफ्यूजन कम हो जाएगी, और एम आई CVA सब कुछ हो सकता है ना। तो एक छोटी सी सर्जरी इंसान को, जो कि इंसान चलता फिरता सर्जरी की टेबल पे आए, वो अपाहज होकर वापस जा सकता है। सो हमें इन चीज़ों का ख्याल रखना है। तो देयर अनदर अदर अदर हाइपर एल्डोस्टेरोनिज्म, मोटे मोटे पढ़ रहे हैं हम भाई। प्राइमरी हाइपर एल्डोस्टेरोन और कौन सिंड्रोम। व्हाट इज कौन सिंड्रोम, कामरान? व्हाट इज कौन सिंड्रोम? हाउ इट प्रेजेंट्स?
It can lead to hypertension
और
and high sodium level, low potassium level, and
patient will be in fatigue most of the times. अच्छा, एक और मजे की बात, whenever there is a mass or there is a tumor which is involving one part of the adrenal gland cortex or medulla, the other part also they might be suppressed or they might be overexpressed. For example, the patient is having hyperaldosteronism secreting adenoma in the adrenal gland cortex, but it will also secrete some of the part of the glucocorticoids, mineralocorticoids, catecholamines, and androgens. So any part, if the patient is having the adenoma in a part of adrenal gland which is excreting androgen, and it is from the childhood, so what will happen to the patient? The androgen, they will be in an excess. If the patient is genotypically male, he might be having the phenotypically female features also. Recently, we have seen the patient who is phenotypically male, genotypically female. He's having the hypertrophied clitoris. He's having the hypertrophied labia with rugae over it. Normal male pattern hair distribution, but he's also having the some small atrophied testes, and he has some rudimentary ovaries and uterus also, with bladder and urethra. So, this is a single adenoma or single thing which has suppressed or overexpressed the male and female both organs inside the body, but both of them are not working, because to keep up with life you have to be in balance with either estrogen or excess or testosterone excess. In female there will be estrogen excess, testosterone will be there, but there is a ratio. And in male, the testosterone should be in excess, but the estrogen should be less. So whenever this ratio is disrupted, phenotypical appearance of that human being will be disturbed. आगे चलो।
Imaging modalities, size of malignancy, risk stratification. Non-contrast CT, homogeneous mass with less than 10 or equal to 10 Hounsfield unit, which is benign feature. Indeterminate or malignant, Hounsfield unit more than 10 requires further characterization. In contrast, enhanced CT, rapid washout test is absolute is more than 60% and relative is more than 40%. Intermediate or malignant shows slow washout, heterogeneous enhancement. MRI, this chemical shift imaging shows fat content in benign feature. Intermediate or malignant shows indeterminate masses in young pregnant or patients. PET or CT scan, low metabolic activity in benign features, and high FDG uptake suggest malignancy. Initial assessment algorithm, start with non-contrast CT if Hounsfield unit is less than 10 or equal to 10 benign adenoma. If Hounsfield unit is more than 10, proceed with contrast washout studies or MRI for definitive characterization. Adrenocortical adenoma, it is a benign disease.
When PET is indicated in adrenal mass, so it is written like in other, for example, in colorectal, in stomach, in GI tract, you deal with PET. You do the PET first and then you do the surgery. In testicular tumor, if it is a non-seminoma, mass is more than 3 centimeter, there is no role of PET CT. But in seminoma, there is role of PET CT if mass is more than 3 centimeter. Mean like it in not in every adrenal gland you do the PET CT to see the activity FDG uptake. But in adrenocortical carcinoma or tumor or mass, if it is locally infiltrative, it is locally malignant, you do the PET CT to see the active component, just to characterize and to counsel the patient that we will not be able to remove all of the mass there. It is very difficult. It is near the aorta and IVC. You deal with it. will be having the massive blood transfusions we have seen recently. ओके, तो ये चीज़ें अपने जहन में रखनी है कि हम एड्रीनल को किस चीज़ पे इवेल्युएट करते हैं. लाइक आरसीसी इज इncidental diagnosis most of the time due to the ultrasound, but the adrenal mass, it is not most of the time incidental. Patient presents you with the symptoms of the particular hormone excess or the mass effect. So you evaluate those symptoms and signs, and then you order the investigation and you get your results back. So to deal with adrenal, it is not a single job of any single or department like radiation department, radiology or urology, general surgery. You have to take the input from the endocrinologist also, because to understand or to maintain the patient's normal living habits accordingly post-operatively or during the surgery. Like in Cushing syndrome or disease, if both of the adrenal glands are excreting excess and you have to block it, and patient doesn't want surgery, you have certain agents like ketoconazole, like spironolactone, to antagonize the excessive production. हमजा कीटोकोनाजोल का मैकेनिज्म ऑफ एक्शन क्या है?
21 hydroxy enzyme, and it is reversible, and which we always given with the steroid.
So ketoconazole, it is a simple antifungal, but it blocks the androgen production via the pathway which has just
21
explained.
hydroxy.
So you can give it only in those patients who's not having the neoplastic phenomena but having the functional adrenal mass.
Adrenocortical adenoma. Size-based management algorithm. If it is equal or less than 4 cm, low malignancy risk. Conservative management with follow-up. The follow-up protocol for the size of 4 or less than 4 cm is 6 months with imaging and hormonal evaluation, 12 months imaging and hormonal evaluation, and 24 months fine imaging plus hormonal evaluation. Surgical indication in size more than 4 cm in functional adenoma, any size, or growth on serial imaging. Medical management for functional adenoma is Cushing syndrome, ketoconazole inhibits steroid synthesis, and Conn syndrome, spironolactone aldosterone antagonist. Yeah. Adenocortical carcinoma is aggressive biology and staging. Platinum staging criteria is less than 5 cm is stage 1, confined to adrenal gland. More than 5 cm is stage 2, confined to adrenal gland. Local invasion of positive regional lymph nodes is stage 3. Local invasion and positive lymph nodes or distant mets are stage 4. It is a rare malignancy with incidence of 0.5 to 2 per million, slight female predominance, peaks in first decade and 4 to 5th decades of life. Clinical presentation, approximately 60% presents with hormone excess, primary aldosteronism, non-functioning tumors presents with abdominal or flank pain due to large mass size, often diagnosed at advanced stage due to aggressive biology. Surgical management, complete tumor resection is associated with favorable outcomes, open surgical approach preferred for large suspicious masses, laparoscopic approach associated with high local recurrence rate. Adjuvant therapy, mitotane is primary adjuvant agent, chemotherapy like etoposide, doxorubicin, cisplatin. In 30 to 50% of cases, adjuvant radiotherapy may reduce local recurrence, restaging every 3 months postoperatively with high relapse risk. Pheochromocytoma. Clinical triad, hypertension, paroxysmal or sustained palpitation and profuse sweating. Its biochemical markers are first-line plasma-free metanephrines or 24-hour urinary fraction metanephrines. Imaging includes CT or MRI abdomen, MIBG scan for extrarenal tumors. There is a rule of 10% extrarenal, 10% malignant, 10% bilateral, and 10% familial. Preoperative protocol, alpha blockade, phenoxypenazimine 20 to 50 mg per day, titrated to achieve controlled hypertension and prevent hypertensive crisis. Volume expansion, increased fluid intake, alpha blockade causes vasodilation and volume depletion. Beta blockade, only after alpha blockade. Propranolol 120 to 140 mg per day or labetalol combined alpha or beta only if tachycardia persists. Preoperative optimization, ensure normal tension, normal heart rate, and electrolyte balance after surgery. Critical safety point, never give beta blockers after alpha blockade. Unopposed alpha adrenergic stimulation causes severe hypertensive crisis. Pheochromocytoma presentation presents with variable clinical features including hypertension, palpitation, sweating, and anxiety. Diagnosis require high clinical suspicion and biochemical confirmation before any invasive procedure. Surgical approach is adrenalectomy. Surgical indication is in non-functioning tumors size more than 4 cm on indeterminate imaging features, high Hounsfield unit, poor washout. Growth on follow-up. Any increase in size on serial imaging warrants surgical consideration. Functional tumors or hormonally active tumors like Cushing, Cons, on pheochromocytoma once biochemically controlled. Suspicious features are imaging findings suggestive of malignancy, ACC, or METs. Surgical approaches are laparoscopic. Indication are benign tumors less than 8 cm with no malignancy signs. Advantages: minimally invasiveness, faster recovery, reduced pain. Limitations are limited for large and complex cases. Open surgery for large tumors more than 8 to 10 cm, suspected ACC, local invasion in distant mets. Its advantages are better visualization, complete resection, and block resection of adjacent organs if needed. Its limitations are increased mobility, longer recovery. Retroperitoneal surgery, selected benign tumors, alternative to retrotransperitoneal approach. Advantages are avoids peritoneal cavity, direct access to adrenal. Its limitations are limited space, requires specialized expertise. Postoperative management and long-term surveillance. For benign adenoma, 6 months imaging, CT, MRI, or hormonal evaluation. After 12 months imaging, CT, MRI, hormonal evaluation. 24 months final imaging and hormonal evaluation. After 24 months, discharge is stable, no further surveillance is required. Adenocortical carcinoma, every 3 months, restaging with imaging, CT, chest, abdomen, and pelvis. Every 3 months, biochemical markers like cortisol, DHEAs, and androgens. Ongoing adjuvant metotrexate therapy with drug level monitoring. Lifelong high relapse risk. Aggressive surveillance is essential. Pheochromocytoma, 24-hour urinary fractionated metanephrine or plasma metanephrine. If elevated, imaging, CT, MRI to assess for recurrence or metastasis. Genetic testing, consider a familial syndrome like MEN2, VHL, or NF1. Lifelong annual biochemical screening for life due to recurrence risk. Postoperative glucocorticoid replacement after Cushing or adrenalectomy. Immediate post-op within 12 hours, 15 mg cortisol parenterally IV or IM. Day 1 to day 2 post-op, 100 mg hydrocortisone daily, then gradually reduce. From the second week to fourth week, transition to oral glucocorticoids, example prednisolone, 5 to 7.5 mg daily. Long-term contralateral gland may take up to 12 months to recover. Critical point: after unilateral adrenalectomy for Cushing syndrome, the contralateral adrenal gland is suppressed and requires gradual recovery. Monitor cortisol levels during tapering to avoid adrenal insufficiency. Summary: key principle in adrenal tumor management. Principle 1: function first. Always rule out hormonal activity before focusing on size or imaging. Pheochromocytoma screening is mandatory in all cases. Biochemical testing guides treatment strategy, prevents life-threatening complications. Principle 2: image interpretation. Non-contrast CT with Hounsfield unit less than 10 or equal is benign. Washout more than 60% of absolute, benign. MRI for indeterminate assets, PET and CT scan for suspected malignancy. Principle 3: size-based risk. 4 or less than 4 cm conservative management with follow-up. 4 cm or more than that, consider surgery. Growth on serial imaging, surgical indication. Follow-up at 6, 12, and 44 months. Pre-optimization. Alpha blockade first for pheochromocytoma. Control Cushing's, Cons syndrome preoperatively. Correct flight abnormalities. Prophylaxis, antibiotics, and coagulation. Clinical integration decision-making framework. Step 1: biochemistry. Screen for all hormones excess like cortisol, catecholamines, and aldosterone. Imaging, assess size and malignancy risk using Hounsfield unit and washout levels. Management, analyze based on algorithm, optimize preoperatively if surgery is planned.
Any question there?
Well, I do not have any question regarding the management, but when Dr. Noman asked regarding role of epinephrine and norepinephrine, in residence, someone replied, and the why you run epinephrine or epinephrine in ICU settings. So someone replied, it's a vasopressor. So do you give vasopressors?
Synaptic level पर वर्क करता है और नॉरेड पोस्ट साइनेप्टिक लेवल पर वर्क करता है नॉरेड आइनोट्रोपिक भी होता है और वेजो कंस्ट्रक्टिव
Exactly,
भी होता
exactly. क्योंकि
है
that is the what I would like to clear कि जो epinephrine होता है ना, that is more that's its potent action is on alpha receptors. That is why it's a drug of choice for in anaphylactic shock. कि वो सिर्फ as a vasopressor act करता है. But in ICU settings you need inotrope 2. तो जो noradrenaline होता है या norepinephrine है, that has also a greater impact on the beta 1 receptors as well. इसीलिए आपको सिर्फ वेसोप्रेसर नहीं चाहिए, यू नीड अ गुड आइनोट्रोप टू. एंड थर्ड वन इज जो आप आईसीयू सेटिंग्स में अक्सर देखते हैं, दैट इज डोपामीन, जो कि डोपामीन इन्फ्यूजन्स रन करता है. ठीक है, तो डोपामीन इज आल्सो हैज अ गुड रोल इन इनिशियल लो डोज सेटिंग्स. डोपामीन कैन कॉज रीनल वेसल्स डायलेटेशंस. अगर आप उसकी डोजेज बढ़ाएं तो दैट बिकम्स अ आइनोट्रोप, और अगर आप उसको हाई डोज पे ले जाएं तो दैट बिकम्स अ वेसोप्रेसर टू. तो डोपामिन के 3 एक्शंस होते हैं, तो इसीलिए डोपामिन इज अ वेरी गुड ड्रग, जो कि आईसीयू की सेटिंग्स में अक्सर आप देखते हैं कि वो चल रही होती है फॉर द सपोर्ट ऑफ द पेशेंट्स. एक और जो बात जो डॉक्टर नोमान ने पूछी थी कि कौन सिंड्रोम के पेशेंट्स में क्या होता है, और किसी रेजिडेंट ने रिप्लाई किया था कि सोडियम की एब्जॉर्प्शन ज्यादा हो जाती है, पोटेशियम की एक्टिवेशन, जो कि नॉर्मल एल्डोस्टेरोन का फंक्शन है. तो बाजों का ऐसे पेशेंट्स होते हैं ना, दे प्रेजेंट्स विद फटीग. आपके पास एक ही चीज होती है कि जो पेशेंट कहते हैं कि मैं थका थका सा रहता हूं, तो फटीग डेवलप क्यों करती है? द रीजन बीइंग ड्यू टू पोटेशियम. ठीक है, द रीजन इज पोटेशियम, द एक्सक्रीशन ऑफ पोटेशियम. अब अगर इफ यू गो ऑन अ फिजियोलॉजिकल लेवल, तो पोटेशियम इज नीडेड फॉर द रिपोलराइजेशन. ठीक है, जब एक्शन पोटेंशियल का आप चार्ट देखेंगे तो रिपोलराइजेशन इज डिपेंडेंट ऑन पोटेशियम. इफ यू डू नॉट हैव द पोटेशियम, आपका जो डिपोलराइजेशन का जो कर्व होगा वो इट विल गेट प्रोलॉन्ग. Once a curve of depolarization gets prolonged, the muscles get fatigued. तो अगर मसल्स फटीग हो जाएंगे तो पेशेंट्स की जो कंप्लेन होगी ना, वो पर्टिकुलरली यही होगी कि मैं थका थका सा रहता हूँ और मेरी जिस्म में जान नहीं रहती. ठीक है, तो दैट इज द ओनली रीजन. और आपको फिजियोलॉजिकल लेवल के पता होना चाहिए. दैट इज अ वेरी गुड टॉपिक टू अंडरस्टैंड द फिजियोलॉजी.
Thank you, sir.